Thanks very much, Daria. I'd like now to introduce our final speaker, Professor Richard Costello, who's a respiratory physician at Beaumont Hospital in Dublin in Ireland. He specialises in asthma and COPD and was involved in the national coordination in Ireland's COVID-19 response.
Good afternoon, or hello everybody, and thanks for taking the time. I'm sure, like you, I've really enjoyed the previous two speakers sharing their experience with technology and how it has a practical value in healthcare. And I'm just going to take that conversation just a little bit further. And we heard quite a bit from our colleagues about the value that they got very quickly from starting to bring in remote monitoring technologies into their practice. And you could see the clear value. They were able to longitudinally collect data on their patients. That data was objective, which is really useful. But I think most importantly, and Daria really made that point so clearly, that it was at home. You could really see that little extra spice of having information collected in the patient's own home. Where I think the real value at the next stage starts to come, and Charles alluded to this in his talk, was what happens when you get data scientists involved and you start to look at combining the data from multiple sources. And that's where the real power of this type of digital, remote, handheld technology starts to come together. And I'm going to illustrate just with a couple of features how it has diagnostic value, how it has predictive value, something that clinicians, despite their apparent crystal ball, don't really have. And I think most importantly, and we've already seen it to some extent illustrated from the two talks, how adaptive this type of technology is to novel situations. Let me explain in briefly. This is a sort of a solution architecture picture. So if you take data, say, on lung function measurement, and then you combine that with treatment use, and perhaps some patient input on their symptomatology into a portal like we've just seen described, and then you run data analysis of this data that's curated in a database, you can then start to see the cause and effect of what treatment is having on lung function and vice versa as over time on the same individual patient. And then you can use that data then to have a sort of a communication that the patient can see these interactions, and also at a more macro scale, like we saw earlier, that the patients themselves can see the data, but also the clinical team can see it at either at an individual level or at a group level. And that becomes very powerful. And let me show you exactly what I mean. This, for example, is the lung function measurement on a patient with asthma. The peak flow is shown here. It's recorded twice daily by a patient. The green is the morning time and the evening is in blue. And just to look along here on this axis, you can see the months going by. So through quite a number of months, through an 8-month period, you can see that this individual's lung function has really done very well. It actually improves quite considerably during the summer period. And then there's a precipitous decline with an exacerbation illustrated here by that red spot where they took a course of oral corticosteroids. What you can see at the same time then is the measurement of their twice daily long-acting beta-agonist inhaled corticosteroid. And in the brown, it may not traject terribly well, is their reliever use. So what you really can see in a very short snap overview is the clinical longitudinal course of the patient with asthma. And you can see, I guess, in this case in particular, that their exacerbation was, in this case, in the autumn, and it wasn't related to poor adherence. So most likely, you'd need to make a treatment change for this individual. So let's go through this diagnostic in a little bit more detail. This is this is the lung function, again showing the peak flow and time over several months here of an individual who started with this. They were symptomatic. They were having a lot of exacerbations. We thought we should really plug them into this remote monitoring severe asthma program. Their lung function, you can see, really was subadequate. The red is shown here to illustrate that it was less than 80% of what we would have liked. You can see these marked variations in morning time, evening peak flow, which are a classic characteristic of asthma. Something that, back in the day, everybody with with the background knowledge of physiology who did a lot of peak flow monitoring would have been well familiar with. We've become less familiar with this as we do point-in-time testing with spirometry. But what's kind of interesting to look at is the coexisting LABA ICS use. So the LABA ICS use is shown here, and on the y-axis you can see the time of the day, and then the time is along the x-axis. We can see the green illustrates that the device has been used correctly. This is a bespoke monitoring device that my research team developed, and what it allows you to do is to understand if the inhaler was taken correctly, in which case it's illustrated in green, or orange if it's taken incorrectly. So whilst this individual is really adherent, particularly in the morning time, perhaps less so in the evening, you can see there's an awful lot of ineffectively taken treatment, which probably explains why the lung function dropped. They weren't so good in the evening. They really were taking it erroneously in the morning, so the peak flow was dropping. So this individual is going to tell you in clinic, oh, I've been taking my treatment, doc. I've been trying my best. And they have. It's just that they were inadvertently making an error. Now, we staged a number of visits where there's feedback given to the patient. So as soon as we recognize this error and did an intervention, you can see that the error disappears. They're starting to be more adherent both in the evening time and the error is going. And the lung function gradually improves. And that's a feature of asthma that we've also caught on to, which is that there's a lag between improving your technique or taking your treatment and actual stabilization of your asthma. Everybody's familiar with this, but the rate at which you improve is actually quite personalized. And that's really important because you can see now this individual is stabilized, but the corollary is true. If they were to slip in their adherence, we wouldn't see a decline in lung function until some period of time later. And just going along with that clinical improvement in their peak flow, this is the beta agonist or the albuterol use. You can see there's a horrendous, a huge amount of albuterol use in the beginning period. And that's probably why the lung function is relatively good up here. So you can see the value of having these multiples of interactions. And then as their airway condition stabilizes, you can see there was a bit of a cluster when it really dropped low. And then as they get better, their reliever use falls away. So you can see this value of the interactions of the multiple data sources. This is another interesting case. This is a patient who, again, on this axis you can see time, and this is months. So you can see that this individual is really tremendously diligent about taking their treatment, punctually and on time, which is excellent. And this is their lung function, which is really very stable. There's some high readings, but basically this is very stable. The value here is running about 500, but they remained profoundly symptomatic. They're asthma controlled. So if you used their symptoms and saw them periodically in the clinic, you'd be very worried because their ACT, their asthma control test, indicated that it's very profoundly suboptimal care. And the reason for that, it turned out, was that by knowing that we got a person who had normal lung function, had been taking their treatment but was symptomatic, that we could attribute their persisting symptoms to an elevated BMI. And that's something that says that we've really got to be careful about symptom as the only way that we can assess asthma control. These data points are also valued predictively. I explained that it takes a little while for a lab ICS to be effective. So a periodic drop-off in adherence may lead to an exacerbation, but you need to know what the person's threshold is. So we've developed, again, by a data science process, a personalized threshold model, a bit like a vancomycin level or something like that. And so if you serially measure the lung function or the treatment use, and you serially measure the lung function, and you have a personalized threshold that the individual works off, you can see, as shown here, their treatment use is staying above threshold. There's a few declines here. They stabilize, but here they drop to well below their threshold, and an exacerbation occurs. So the reason for this is that this would be the time to intervene. If your dashboard illustrated that the threshold had been breached and they were sub-threshold for a period of time, this would be the time for a nurse practitioner or one of your colleagues or yourself to call and say, listen, you're below threshold, you're liable to run into an event if you don't start to use your treatment a little bit more regularly. Finally, I said they're adaptive, and we've talked about COVID, and just to illustrate how adaptive digital technology is, We developed a score when COVID came in. We read from the Chinese literature that there were a number of pre-morbid risk factors that were responsible, like obesity and hypertension. But we also realized that that was only good for telling you that somebody was going to run into trouble, but not when. And obviously, as Charles indicated, it was a lot of ARDS. So we developed a score of respiratory distress involving not just how much oxygen they were getting, but what the SATs were like and how much non-invasive ventilatory support they were getting. And we called this the CCI score. And when we layered that risk factor on top of their baseline risk, we could plot over time. So we developed this app that our house staff used, and that we could plot every couple of hours what the CCI score and the individuals were. So here you can see somebody who starts with quite a high risk score, but over time they spontaneously recover. This individual, on the other hand, didn't do so well. And the real value to this was we were able to predict 12 hours or 24 hours before that they were going to need an ICU bed. And I could do my ward round starting with the patients in the red zone and then the orange and then the green, rather than starting my conventional ward round, on a particular ward. And this allowed me to concentrate. I could do the handover on these patients and so on and so forth. This illustrates the value to this type of digital technology. And our score and baseline score were very predictive of ICU use. So to summarize, I think digital technologies are able to improve clinical care. We've heard diarrhea, we've heard Charles talking about their own personal experience in the remote COVID clinic, in keeping folks with transplantation safe and well and away from trouble and delivering really, preemptive and adaptive care. And I'll illustrate that you can do this in multiple other diseases. I've illustrated the diagnostic value in asthma, its predictive value in asthma, something that we really have not had before. And together, depending on the situation, depending on the patient's own needs, we can make these systems adaptive. So I think there's a huge, huge potential for these technologies going forward. Thank you for your time.